Good morning. I'm Dr. Vijaya Lakshmi. I'm from Gynecology Department. Today, I'm going to discuss about antenatal care in detail. What is antenatal care? It's a periodic and regular supervision, including examination and advice of a woman during pregnancy is called antenatal care. Okay. So, why antenatal care is needed? What is the purpose of antenatal care? The purpose of antenatal care is to screen the high-risk cases, to prevent or detect and treat at the earliest complication. So that if we detect any complication in the beginning of the pregnancy, we can treat it immediately. So we no need to wait for until the further complication occurs until it becomes worse. So that if we can detect early and we can treat it early. Most of the time we can prevent the complications itself. So another thing is to ensure continued medical surveillance and provide primary preventive health care. And one more thing is to educate the mother about the physiology of pregnancy and labor, especially in case of primary gravidas, that is first pregnancy. Young mothers, they are not aware of what is going on in their body. So they are unaware of the pregnancy changes. They might be, it looks weird for them, so that we can explain the physiology and what are the changes occurring in the mother in the pregnancy and what is the process of the labor, so that we can educate them in the regular antenatal visits. We can discuss about the place and time and mode of delivery with the couple during the antenatal visits. And we can motivate the couple about the family planning. In case of primary gravidas, about the spacing and the different types of contraceptive methods. In case of multi-gravidas, we can motivate for them permanent sterilization by tubectomy. And finally, we can explain the mother about the breastfeeding and postnatal care and immunization, so that mother is aware of all these things since the beginning of the pregnancy. So it should not become at that moment. It has to be from the beginning. What are the objectives of the antenatal care? The main objective is to ensure a normal pregnancy with the delivery of a healthy baby from a healthy mother. What is a normal pregnancy? Normal pregnancy means delivery of a single baby in good condition at term with no maternal complications. That is the normal pregnancy. In case if it is twins, it is not normal. If it is a preterm, it is not normal. If mother is landed in any complication, that is not normal. The normal pregnancy means a single baby and both mother and baby should be safe and the baby should be born at the term. That is when the baby is grown to the proper weight and has reached the proper criteria for the normal pregnancy. That is normal pregnancy. So antenatal care, we are talking about the antenatal care. How often the patient has to visit us for the antenatal care? According to WHO, these are at least 4 visits. It is not compulsory, it is not regular, at least. Where the resources are very less, at least 4 visits. The first visit is around 16 weeks, and the second visit is between 24 to 28 weeks, and the first visit and the third visit is at 32 weeks, and the fourth visit is at 36 weeks. These 4 visits are the people where the less resources and they are less access to the antenatal care. But in general, in our antenatal clinics, the schedule of antenatal visits is once in a month up to 28 weeks. That means up to second trimester. And first trimester and second trimester, we have to check the patient. We have to see the patients once in a month. Every month, patient has to come to us and has to take the take the checkup. And after 28 weeks, that means in the third trimester, up to 36 weeks of gestation, every 2 weeks. After 36 weeks until delivery, every week. In case of any complication, in case of any abnormal pregnancy, any complication, any problem arises, the patient has to visit more frequently. So we need to increase the frequent visits. In case of PAH, pregnancy-induced hypertension, the patient visits every 2 weeks since even second trimester, since 20 weeks itself, the patient visits us every 2 weeks. What is antenatal care? what it consists of. Antenatal care consists of careful history and examination and the investigations. In the first visit itself, in the antenatal clinic, the first visit will take the careful history and we examine the patient and we do the routine examinations. And according to these examination history and investigations, she will be given advice. Accordingly, considering all these three, we have the woman, if it is normal, everything is normal, she will be coming to the normal regular visits, like what I have told, how frequent the antenatal visits. For the first 2 trimesters, once in a month, and from 28 weeks to 36 weeks, every 2 weeks, from 36 weeks onwards, once in a week. That is for routine. If that is advice given to the normal, if it is normal. In the history, if we see any problems and the examination, if we find any problems in the investigation, if anything is abnormal, the advice is given to the pregnant woman according to the patient condition, according to the mother's condition, advice is given. So what we ask in the history, I will explain in detail, but I'm giving what are the things we will ask in the history. Particulars of the patient, chief complaints with the duration, past history, obstetric history, menstrual history, family history, drug history, and a history of immunization, socioeconomic history, contraceptive history, and history of allergy. These are the things we ask in the history of a patient. I will explain you each and everything in detail. What we ask, what are the particulars we ask the patient? We will ask the patient name, that is her identification, age. If it is mother is young, age is important. Why age is important? If it is young mother, there are the certain criteria, so there are the certain things for the mother. If it is elderly primary, there are the certain problems to the mother. So the age is plays very important role in pregnancy. Address means the location. Some diseases are endemic to some places, so depending on the address, if she is in a tribal area and she is in some places like where the thyroid or iodine deficiency is endemic, so that we can take care of the mother. So that locality is also important. Marital status, it is also important. Some in case of unmarried, we need to explain the parents, we have to inform the parents and the social services, and we should be taking care of the legal issues. So that marital status also we have to ask her. And marital status is how long she is married. That is important. If it is precious pregnancy, because she conceived 10 years after marital life, that is very precious. So that we need to increase the regular antenatal visits. We have to take care of so many things, and we need to plan the pregnancy and the termination of the pregnancy. So many things are there about the marital life. Socioeconomic status. So in case of low socioeconomic status, about the nutrition deficiencies and anemia, they should be taken care of. So particulars of the patient is important to take care of the mother. And about the chief complaints. In the first antenatal visit, we may not come with all these complaints, but in each visit, she might come with some of the complaints. She might not come with the complaints. These are the usual complaints in the regular antenatal visits. In the first trimester, the most common complaint is nausea and vomiting. This is common. And the second one is increased frequency. I will explain about these things also in detail in the next slides. So the complaints in the antenatal visits, these are the regular complaints. These are may not be all these complaints. 1 or 2 of the complaints will be the frequent complaints what we see in the antenatal visits. The complaints are nausea and vomiting, increased frequency of micturition, constipation, heaviness of breast, rise of temperature, edema, pain in the abdomen, backache, and vaginal bleeding. These are the complaints. If they come with these complaints, if in case nausea and vomiting, how frequently, how many vomitings, and we have to ask in detail about each and every complaint along with the duration and aggravating factors and relieving factors, so that we can advise her. And we have to ask obstetric history. We have to ask her gravidity. She is primigravida or multigravida? In case of multigravida, we have to ask about the parity, whether it is a live birth or abortion or any stillbirths. We have to ask about the gravidity, parity, and abortion in this in the obstetric history. And weight of the in case of second, this is her second pregnancy or third pregnancy, we have to ask about the previous pregnancy, about the weight of the baby, the first baby, and the period of gestation, when she gave birth to the baby, whether it is a term pregnancy or a preterm delivery, so that we can take care of present pregnancy and type of delivery, whether it is vaginal birth or cesarean section, and the location of birth, whether it is in the home delivery or in the hospital delivery, institutional delivery, so that we have to inquire each and everything about the previous delivery also. And she landed with any complications, whether the mother or the baby has had any complications in the previous pregnancy. So because many complications has recurrences in further pregnancy, so that we have to inquire about all the complications in the previous pregnancy, both for mother and baby. And we have to inquire about the menstrual history. Why menstrual history is important? Menstrual history is very important because whether her cycles are, we have to ask about age of menarche, menstrual cycle, and last menstrual period, and we have to calculate ED. Why it is important? In case of regular cycles, the expected date of delivery is calculated very easily. That is 9 months 7 days is the expected date of delivery from the last menstrual period. In case of irregular cycles, we cannot rely on the last menstrual period, so that we have to immediately advise to take one ultrasound, and it is more reliable, so that in the first trimester, if she is in irregular cycles, we have to rely on the scan for the expected date of the delivery. The past history. Coming to the past history, we have to ask every patient about the past history. Now, every antenatal mother should be inquired about her past history. Whether she is hypertensive before pregnancy, whether she had any diabetes mellitus, and whether she has any thyroid disorders, and she has any bronchial asthma since childhood, whether she has any renal diseases and cardiac diseases, and any she had at any time she had any tuberculosis, and whether she had any surgeries in the past. So that we can, if she has any medical conditions, whether she used or whether she is using any medication for that, we have to take care of these medications in the present pregnancy. We need to ask about the drug history, as I told you about hypertension, diabetes, and other things is antidepressants. Sometimes she might be these days depression is one of the commonest thing. So whether she is using any antidepressant, corticosteroids, anticoagulants, if she is using any of these drugs, there should be a medical advice to be given to the mother, because many of these drugs have the negative effects on the growing fetus. So that it is very important to ask about the drug history. And moreover, we have to, she might be having any allergies to any drugs to be asked, so that we can avoid those drugs. Family history, in the same way as past history, we have to inquire about family history. Hypertension, diabetes, thyroid disorders, multiple pregnancy, and there are the chances of any twins in the pregnancy. In case of twin pregnancy, there are the chances of in the in the family, in the multiple pregnancy, twins, cardiac disorders, and any family history of tuberculosis. That is also very important, especially in tribal areas. So that we will be doing some tests for them, so that we can exclude these disorders to the pregnant lady. So assessment and physical examination, and in each antenatal visit we have to do the examination, general examination and abdominal examination. In each antenatal visit we have to examine the patient. Without examination we should not give the advice to the mother. We have to examine thoroughly. In general examination and abdominal examination. In general examination, we see the patient. By looking at the patient's appearance, we will give some clue whether she is healthy or not. Sometimes she looks fatigued, she looks paler. By looking at her appearance only, we can assess the mother is healthy or not. Appearance, height of the patient, weight of the patient. Height of the patient, we will measure the height of the patient in first antenatal visit. Weight of the patient, we have to weigh the patient in each and every antenatal visit. Based on that weight of the patient, how she is gaining and she is losing the weight, we can take care of the patient. Anemia, jaundice, edema, cyanosis, clubbing, poilonicia, lymphadenopathy, all these should be examined in each and every visit, except the height of the patient. Weight measurement. Maternal height and weight measurements to be determined in the first antenatal visit. What we do, we measure the height and weight. Based on that we calculate BMI. So if BMI is not obese, it is okay. If it is obese, we have to take care of not to gain too much weight in the pregnancy. So she might be landed up in so many complications. So that this BMI calculation is very important in the first visit. And maternal weight should be measured in each visit, because if the weight gain is also plays a role in the antenatal care and different complications. In case of about the weight, in case of pregnancy induced hypertension, and more weight gain and more edema within 1 month. Suppose she has to gain weight of 2 kgs in 1 month in the first 2 trimesters, but she gains more weight, means 5 kgs weight. We have to keep an eye. Something is going wrong, so that we have to start evaluating what is happening to the mother, and check for the pallor or anemia. Now look for the palm. How we check the whether in examination, how we check the pallor. So we have to look for the palms and conjunctiva to assess anemia in general examination. Once if you feel, usually we do in the first antenatal visit and in the middle, and in 3 to 4 times we do hemoglobin. But in case of at any time, if we see in general examination, if you see she looks paler, we have to advise hemoglobin and complete blood picture. In general examination, we have to measure the temperature, pulse, blood pressure, respiratory rate, and breast examination, and heart sounds. We have to auscultate heart and lungs. And we have to measure in each visit. We have to measure the blood pressure. Measuring the position should be in sitting position, right hand, and we have to measure the blood pressure. We should not, because many people will check the blood pressure on lying down position. It is not right. It is the sitting position. A right hand should be on the table, and the BP operator should be, the mercury level should be at the heart level. That is the correct level of the measurement, correct way of measurement of blood pressure. Abdominal examination. In each visit we have to examine the abdomen. Inspection, palpation. These are inspection, palpation, percussion, and auscultation. In first antenatal visit, we just see inspection and palpation. There are no until 20 weeks, 22, 26 weeks. We don't do auscultation and percussion, these things, because abdomen is that is uterus is too small, and we can't hear any fetal heart on auscultation until 24 to 26 weeks of gestation. Inspection. On inspection, we'll see the shape of the uterus. So in case of any coexisting diseases in pregnancy, the shape of the uterus is the shape of the abdomen is distorted. Usually it is ovoid. It will be the shape is distorted. So that on inspection only we can assess whether anything is going wrong, and and baby's lie also we can assess. And striae, these are the stretch marks, and striae gravidarum and scar marks, any scars during the pregnancy. We have to see all these things in each visit. Palpation, palpation of what are the things we do and what are the things we see in the palpation. We can palpate by keeping our right hand ulnar border. By that we can measure the fundal height, and on palpating the fetal parts we can assess the lie of the fetus, whether it is vertex or transverse lie or bridge presentation. So that depending on the lie, the management varies. So that we have to, that is also we can diagnose in palpation. Abdominal girth, we have to measure the abdominal girth with the tape, and abdominal fundal height also will be calculated by palpation, and we have by the measurement also. Fundal grip, lateral grip, first pelvic grip and second pelvic grip, these are done in term pregnant woman, so that we can assess whether the first fundal grip, lateral grips, this gives the idea of the position of the lie of the baby, and the pelvic grips gives the whether the baby is engaged or not. In auscultation, we hear the fetal heart rate. The normal fetal heart rate is 120 to 160 beats per minute. But what is the fetal tachycardia? If it is greater than 160 beats per minute, it is tachycardia. If it is less than 120 beats per minute, it is bradycardia. What are the causes of tachycardia? And tachycardia will be caused in case of maternal fever, in case of fetal distress. Even if mother has tachycardia, suppose mother is anemic, mother has a chance of tachycardia. If mother is having tachycardia, there are the probability of having fetal tachycardia. So these three things should be come in our mind when there is fetal tachycardia. What are the causes for fetal bradycardia? And fetal distress, as for fetal tachycardia, fetal distress might cause fetal tachy or fetal brady. Fetal cardiac conduction defects also causes fetal bradycardia. So what are the investigations to be done? In the first antenatal visit only, we will do what I told you. In the first antenatal, after history, and we'll examine the patient and investigations to be done. In the first antenatal visit itself, we'll do all the routine investigations like complete blood picture, which includes hemoglobin, blood grouping and typing. So that in rare blood groups like O negative blood groups, O negative, AB negative. So we should be make availability of the blood, because we can't predict how the pregnancy is going. In case of any complication occurs, we can't run around. So that we make the blood group in case of negative groups and rare group, donor will be make sure to available the donor. So that blood group and typing is important in case of negative pregnancies. In case of RH negative pregnancies, and we have to go for, we will check antibodies by indirect womb test, whether she has immunized before. We have to ask about these things: hemoglobin, blood grouping and typing, urine analysis, and VDRL to screen for syphilis, hepatitis B, surface antigen, and HIV and thyroid profile. These are the investigations to be done in the first antenatal visit. And in the first trimester, we have to do one ultrasound. Early pregnancy, that is preferably 10 to 13 weeks. Why it is important at 10 to 13 weeks? To determine the gestational age. Usually, gestational age is determined by last menstrual period. But in case of determine the gestation. In case of irregular cycles, we cannot we cannot rely on the last menstrual period, so that we can measure the gestational age based on the early scan. And we can to detect multiple pregnancies and help with the later if it is if we do a 10 to 13 weeks, so we can see the nuchal translucency, which is helping with the one of the marker of Down syndrome. At 11 to 14 weeks, offer nuchal translucency screening for Down syndrome, those who are at high risk for Downs, that is elderly primary gravidas and family history of Down syndrome, any chromosomal problems in the family, so that we have to go for ultrasound and nuchal translucency at 11 to 14 weeks, and we have to do the double marker test in case of the screening of Downs. So that these are the investigations to be done in the first trimester. All the routine investigations along with the high-risk mothers about Downs, we have to do these ultrasound along with double marker test. And if everything is okay, if the cycles are regular and the scan is correlating with the last menstrual period, and we can calculate the EDD, expected date of delivery, very easily, and we can go with the gestational age. In case of discrepancy between, in case of wrong dates, in case of very irregular cycles, so in the first trimester scans is more reliable than the mothers what they are giving the history, because they might have forgotten the dates and there might be irregularity of the cycles, so that it is very important to take the ultrasound in the first trimester for the not only for the well-being of the fetus, for calculation of gestational age. And the second scan is offered at 18 to 20 weeks of gestation for the congenital anomalies. Any anomalies can be detected at this gestational age. We cannot delay more than 21 weeks. Most of the anomalies cannot be detected at later gestational age. So that every antenatal mother is offered TIFA scan, that is targeted imaging of anomalies of the baby at 18 to 20 weeks of gestation. And if everything is going smooth, and in antenatal visit, if it is everything on our physical examination and general examination, if everything is good, no need to do too many ultrasounds. No, so before the 36 weeks, we have to do one scan for the fetal estimated fetal weight and the liker and position of the baby, so that 3 scans will be enough. But in case of at any time there is a disparity between the dates and abdominal girth and fundal height, any clinical assessment is different from the gestational age, so that we can offer some other scans. So that in case of IUGR, serial growth scans should be needed. And these are the investigations. Those are the routine blood investigations, and the scans are the things to be done in the first antenatal visit, and the subsequent scans are also 2 scans. But after that, other than in the first antenatal visit, what are the things we have to ask the mother in the subsequent visits? In each visit, we have to ask, do you have any complaints? And we have to ask whether she is pursuing fetal movement well or not, whether she looks good or not in general examination. And we have to calculate the gestational age, and we have to measure the symphysis fundal height, and educate the mother about the pregnancy. In each visit, we have to make her prepare for the pregnancy and breastfeeding and delivery. She has to be educated in each visit. So we can prophylaxis and supplementation of food, about the supplementation of vitamins in each and every visit, and prophylaxis and treatment of anemia, developing of individual birth plan. These are the things to be educated in each subsequent visits. These are the things at each visit what we do. This blood pressure measurement here. Here is the symphysis fundal height. We have to auscultate the fetal heart and measure the weight, and urine for albumin. To check urine for albumin. That is why urine for albumin is important. To predict any pregnancy-induced hypertension, and to predict infection. In case of albumin is high, we need to evaluate for that. Any complication is there. This is how to measure symphysis fundal height. That is from the symphysis pubis to xiphisternum. That is measured in centimeters. It corresponds to the height is measured in centimeters. It corresponds to the weeks of gestation. If it is 36 weeks, 36 centimeters, that is 36 weeks gestation. If it is 28 weeks, 28 centimeters, 28 weeks of gestation. This is how the correlated with the symphysis fundal height. In the third trimester, we have to do the fundal grip, lateral grips, and pelvic grip. In the fundal grip and lateral grips gives the idea about the fetal parts, the position of the baby, and lie and engagement. In pelvic grips, we can get idea of the engagement of the head. These should be, the grips should be done in third trimester, not in early weeks, because the fetal position is not stable in the early weeks. The fetal keep on moving, so that the lie is not stable and head is not engaged, so that we don't do any pelvic grips in the early pregnancy. Only it will be done at term, especially in third trimester, especially at the term. What is the antenatal advice? So patient is coming to us. She came to first antenatal visit. We have done all the investigations. We advised about the we advised for the investigations that everything came normal, and we advised to come regular visits. We are doing examination in each and every visit, and we are asking about the complaints in each and every visit. But what are the advice to be given to the mother? But these are the common things. These are the each and every mother need to be advised about these things, about the diet, rest and sleep, bowel, personal cleanliness, clothing, shoes, belt, dental care, care of breast, coitus, traveling, smoking and alcohol, immunization, drug, mental preparation, exercise, child care, birth plan, warning signs, family plan. These are all the things to be given advice to the mother. I will explain each and everything in detail in next slides. So what is the diet to be advised in pregnancy? In case of pregnancy, normally normal diet is not enough for antenatal mother, because the growing fetus needs more and more calories, and to meet the demands increased in pregnancy, we need to provide with extra calories. Total caloric intake increased to be 300 calories per day due to 15% increase in BMR. Diet should contain more protein, 20% protein, 30% fat, and 50% carbohydrate. Sufficient fluid should be taken. And this is the daily requirement of a pregnancy woman. Normally, for a woman, the daily recommended dose is 2,200 kilocalories. But for pregnancy, extra 300 calories. During lactation, extra 550 calories is needed during lactation. During pregnancy, from second trimester onwards, extra 300 kilocalories are needed. Protein should be 60 grams, iron 40 grams, 40 milligrams, folic acid for 400 micrograms, calcium is 1000 milligrams, and vitamin A 6000 international units. These are per day. Each and every antenatal mother is supplemented with folic acid 400 micrograms daily, and iron, elemental iron should be 100 mg per daily, and daily 1000 milligrams of calcium is required. So as I told you in the previous, weight gain. What is the importance of weight gain here? In each and every visit we measure the weight. What is the importance of weight gain? There is a slight loss of weight during early pregnancy if the patient experiences much nausea and vomiting. Weight gain of 2 to 4 lbs, that is 0.5 kg to 1 kg by the end of the first trimester. Usually she won't gain more than that. If she gains weight more than half kg per week expected during the second and third trimesters. Monitoring of weight gain should be done along with blood pressure. There is a correlation between excessive weight gain and blood pressure. And breast care. Because there are so many changes in the body, physiological changes in the body in the pregnancy. This is one of the physiological changes. preparing the mother for feeding. Wash breast with clean tap water. It is not recommended to massage the breast. This may stimulate oxytocin hormone, and which subsequently it stimulates the uterine contractions, and preterm delivery chances will be there. So don't massage the breast. Just to clean with the tap water, and advise the mother to be mentally prepared for breastfeeding. So otherwise, if the mother is not prepared well for the breastfeeding from the beginning, after delivery, she might be having difficulties in breastfeeding the baby. And these are the changes in the breast. Normal breast this is the normal breast. In the early pregnancy, these are the increased pigmentation and the increased areola. In the secondary areola, it's development of secondary areola and pigmentation is increased in late pregnancy. Dental care. The teeth should be brushed carefully in the morning and after every meal. Encourage the mother to see her dentist regularly for routine examination and cleaning. A tooth can be extracted during pregnancy, but local anesthesia is recommended. About the dressing, avoid wearing tight clothing because it might impede blood circulation. Suggest wearing shoes with moderate to low heel to minimize the back pain. And the loose and tight clothes are more comfortable. So this is about the dressing. Sexual activity. About sexual activity, sexual intercourse is allowed with moderation, is absolutely safe and normal unless specific problems exist such as vaginal bleeding or ruptured membranes. If a woman has a history of abortion, it should be avoided. Sexual intercourse should be avoided in early months of pregnancy. Exercises. Pregnancy exercises. We can take the advice of the doctor, or to take the exercise should be simple. Walking is ideal, but long period of walking should be avoided. The pregnant woman should be avoid lifting heavy weights. She should avoid long period of standing. She should avoid sitting with legs crossed because it will impede blood circulation. Sleep. Adequate sleep is needed in pregnancy. Sleep for 1 or 2 hours in the afternoon, and at least 8 hours sleep should be obtained every night, so that highest level of growth hormone secretion occurs at sleep. Advised and women to use natural sedatives such as warm bath and glass of warm milk. Don't use medication drugs to get sleep. Travel. This is the most common thing many women ask, because most of the Indian women go to the mother's house for the delivery. So that 80 to 90% of the women in the antenatal clinics, they have regular antenatal checkups at one place, they go to delivery to other place. So traveling is almost in each and every patient will travel. So it might be a short travel, maybe long travel. So advice is very important. Travel advice is very important for every pregnant woman. Early in normal pregnancy, there are no restrictions. Unless she has nausea and vomiting, she cannot travel. It makes her more sick. So that she doesn't have any problems in the early pregnancy, there is no restriction for travel. But late in pregnancy, travel plans should be take consideration the possibility of early labor. So that it is better to avoid traveling after 32 weeks. Air travel is allowed until 32 weeks. It is if it is less than 3 hours. If it is more than 3 hours, air travel is not allowed after 28 weeks of 28 weeks of pregnancy. Hygiene. Daily bath is recommended as it is stimulation, refreshing and relaxing. Avoid hot water bath. Bowel care. As there is increase of chance of constipation, regular bowel movement may be facilitated by regulation of diet, taking plenty of fluids, vegetable and milk. And every patient should be aware of every antenatal mother should be aware of the dangerous signs of pregnancy, so that she can consult any dangerous signs occurs. She will be alerted about these signs. Vaginal bleeding including spotting, that is also a dangerous sign. And persistent abdominal pain, severe and persistent vomiting, sudden gush of fluid from vagina, absence or decreased fetal movement, severe headache, edema of hands, feet, face, fever above 100 degree Fahrenheit, dizziness, blurred vision, double vision, painful urination. What these dangerous signs indicates? Vaginal bleeding, including spotting, we have to rule out any abruption or placenta previa, so that it is very dangerous sign. If anything, any of those two is a high risk pregnancy. Persistent abdominal pain, we have to, if she is mild on and off pains or Braxton Hicks contraction is normal, but persistent abdominal pain not relieving, that means she might be having any surgical emergency, maybe appendicitis and ovarian cyst torsion, so many things will be there. She will be that is also danger. She must have visit the doctor. Severe and persistent vomiting, hyperemesis gravidarum is also one of the things to rule out any other abnormalities. Sudden gush of fluid from vagina to rule out premature rupture of membranes, which will give the preterm baby and premature, and it is risk to baby. Absence or decreased fetal movement to rule out any stillbirth, any IUG or any IUDs, so that is also one of the dangerous signs. Severe headache, edema of face, feet, legs, that means we need to rule out preeclampsia, pregnancy-induced hypertension. Fever, it is a maternal fever, causes fetal distress. And is in high-grade fever, there are the chance of sudden fetal death. So that is also one of the dangerous signs. Dizziness, blurred vision, double vision, these are the signs of pregnancy-induced hypertension. Painful urination, any UTI should be treated in pregnancy. So those are the major things. We have to, dangerous signs are about the major things. These are some minor complaints during pregnancy. So many antenatal mothers come with some minor complaints. Almost every antenatal mother has any one of these minor complaints during their pregnancy. So we have to manage these minor complaints without medication. Gingivitis, increased vascularity and hypertrophy of the interdental papillae. It is improved usually after pregnancy termination. Because of this gingivitis, increased tendency of bleeding, retention of food debris, and predisposed to sepsis. The only thing for this gingivitis is maintaining dental hygiene. Otherwise, because we have to assure her it will be improved after pregnancy termination. And sialorrhea, increased salivation may occur early in pregnancy. It is due to failure of the patient to swallow the saliva rather than increased amount. This is also care of dental hygiene. Discontinue smoking. Heartburn. This is most common complaint by most of the antenatal mothers. That is gastritis, reflux of gastric content into the lower esophagus due to the mechanical relaxation of the cardiac sphincter caused by upward displacement and compression of the stomach, and because of progesterone, that is relaxation of the all the motility is decreased. Along with all intestines, the motility of the esophagus and stomach is also decreased, so that it allows the food to be in the stomach. It won't transit very quickly, so that there are the chances of reflux. How to manage this heartburn? More frequent but smaller meals, avoidance of lying down or sleep immediately after taking food, and in case of it is severe, take antacids. Constipation, as I told you, in the heartburn, it is also due to reduced intestinal motility due to hormones and increased fluid resorption from the large bowel, and reduced because of the pregnancy. We don't do brisk exercises. So reduce the exercises, and mechanical compression by the gravid uterus also causes constipation. To avoid this, how to manage these constipation means increase the fluid intake and diet rich in green vegetables, bran and fruits. Hemorrhoids. This is also one of the complications which we frequently see in antenatal clinic. That is laxity that occurs due to laxity of the rectal veins by progesterone effect. This is hemorrhoids usually by progesterone effect and constipation. and the constipation also predisposes to hemorrhoids. Almost every antenatal mother takes iron tablets. Most of the times there are the chance of constipation because of the iron and because of the less take of water and less water taking and less mobility. So there is a tendency of constipation. Because of that constipation, there are the tendency of hemorrhoids. Too much straining causes hemorrhoids. Pressure by the gravity stress is also causes hemorrhoids. How we manage the hemorrhoids? First thing is avoid constipation. That is the first thing. And soothing and astringent agents, local anesthetics to be given. As much as possible, surgery is avoided. Varicosities. Increased venous pressure by compression with the pregnant uterus. Increased venous pressure by compression with the pregnant uterus and prolonged standing and relaxation of vein walls by steroid hormones causes varicosities. How to manage this varicosities? Varicosities can be managed by avoid prolonged standing, encourage active exercise, elevate the legs in higher level than the body during sitting and sleeping, and elastic stockings are worn while the patient is lying down and veins are empty. And surgical or injection surgeries are all the surgeries mostly avoided. Dyspnea. It may occur early in pregnancy due to hyperventilation caused by progesterone. Late in pregnancy, it occurs due to pressure on the diaphragm by the pregnant uterus. So it is, first to certain extent, dyspnea is physiological. But if it is too severe, if it is high grade, she need to consult a physician to rule out any cardiac diseases, any lung and heart and lungs problems, urinary symptoms. Frequency and stress incontinence may occur during pregnancy. In early weeks, increased frequency due to enlarging uterus is a pelvic organ until 12 weeks. At that time, the first trimester, the enlarging uterus compresses the bladder, increases frequency. But in the later and the second trimester, it will come to the normal. In third trimester, again, because of the growing uterus, increases the abdominal pressure. So that increased frequency and stress incontinence. Leukorrhea. Increased vaginal discharge is common complaint during pregnancy due to excess estrogen production. No treatment is needed except if there is an associated infection. And Monelian infection is common because of decreased vaginal pH, and in case of any diabetes, in any gestational diabetes, there are the chances of fungal infections. Leg cramps. This is the most common complaint in each and every antenatal mother. So this is, we have to educate her. This is due to insufficient calcium levels and increased demand of the growing fetus for the calcium, so that she should be provided with calcium supplementation and massage of contracted muscles and passive stretching. Backache. This is also one of the most common complaint, but this is minor complaint. These are the causes are lumbar, the posture of the, because of the growing growing uterus, the posture will be changed. The lumbar lordosis position, that is also causes back pain, and the relaxation of ligaments and intervertebral disc by progesterone effect, preparing the pelvis to accommodate the baby and for the engaging the to deliver the baby through the pelvis. So this causes backache. How to manage this is adequate rest and support the back when sitting in a chair by pillow. Avoid wearing high-heeled shoes. And this is the antenatal care, about the major and minor things what we see in each and every antenatal visit. And the first antenatal visit, certain investigations to be done, and in between any in examination, if we notice anything, we do the test, repeat the test like hemoglobin, urine examination, and any depending on the condition, we will go for some other investigations and ultrasound. These are the things in the antenatal care. But the preconceptional care is the one step ahead of the antenatal care. When a couple is seen and counsel about the pregnancy, its course and outcome before the time of actual conception is called preconception care. That is a step ahead means before the conception, so that it will be more useful. Why it is useful? objective is to ensure that a woman enters the pregnancy with an optimal state of health, which would be safe for both mother and baby. So, because if the mother and the couple visits preconceptionally, that is before planning pregnancy, there are the chances of identification any high risk factors to any of the couple, and especially mother, and base level health status, and any vaccinations required, rubella and hepatitis immunization, and folic acid supplementation prior to 3 months of the pregnancy to avoid any neural tube defects. Maternal health is optimized preconceptionally so that the mother is healthy before the pregnancy, so that she can give birth to a very healthy baby. Patient with medical diseases like hypertension, diabetes, or which are on medication will be stabilized and optimal state by intervention. And if any medical condition, if the mother is using drugs before pregnancy, they're verified, changed if required to prevent any adverse effect on the fetus. Example, warfarin is replaced with heparin because warfarin causes anomalies in the baby, and anti-diabetic drugs will be oral drugs will be having negative effects on the baby, so that it will be replaced with insulin in pregnancy. So that these are the things to be taken care of prior to the pregnancy, so that a healthy baby, there will be the chances of having nil effects of the drugs on the baby. Advice to stop smoking, alcohol, and drug abuse. Proper counseling to be to those with history of recurrent fetal loss or family history of congenital abnormalities. Counseling regarding health care cost. Find out supporting our health in case of people are separate, the couple are living away from the family, so that if they are planning, we can advise them what is the things going in the pregnancy, and so that they can help someone, they can find someone to help them when they need it, as for mother and baby. Okay, this is about the antenatal care. Thank you. Any doubts?